Okay. Next up, we have the STI services and Harford County overview, and it's going to be presented by Linda Boegner and Zach Kosinski. I'm going to give you a little background first up. Linda Boegner is the director of the Clinical Health Bureau for the Harford County Health Department. She has expertise in the area of infectious disease and public health policy and promotion, specifically including STI clinical treatment guidelines, prevention and education, HIV and hepatitis C screening, treatment, and case management, as well as education and care regarding drug user health. She has worked as a nurse in other settings, ICU, trauma, nursing instructor, school system for over 30 years, since 1980. She has worked at the health department since 2013, now with a dual role as administrator and clinician. Zach Kosinski. Zach is currently the Deputy Director of the Clinical Health Bureau at the Harford County Health Department. He has overseen the harm reduction unit programs, including PrEP, overdose prevention and response, and other drug user health services since 2019, and now also administers the HIV health services, community-based HIV and Hep C testing, hepatitis C, case management, tobacco prevention, cessation and enforcement, and outreach and education programs at the Harford County Health Department. Zach is a registered peer supervisor, certified peer recovery specialist, a certified community health worker, and sits on the Maryland HIV Planning Group and the statewide services program standing advisory committee. He is currently pursuing his MPH at Johns Hopkins Bloomberg School of Public Health, where he is a Bloomberg Fellow and of addiction and overdose.
Thank you so much for the intro, Greg. I'm going to shift the mic up just a tiny bit for myself, Linda. I think you might be good, but the next presenter afterwards might need to shift it down. As Greg said, I'm Zach Kosinski. I'll be taking us through the first half of this presentation, and then Linda will be taking us off through the second half. We really appreciate you being here today. Also want to recognize for all the folks that are calling in virtually who may be from other areas outside of Harford County. A lot of the data and information we're going to share about services is specific to Harford County, Maryland. But we think that given the recent trends in recent years with the pandemic, that a lot of the information should be relevant to other jurisdictions as well. Just an overview. We're going to go over quickly the local epidemiology of chlamydia, gonorrhea, and syphilis. We're going to talk about HIV epidemiology, hepatitis C. We'll briefly mention disease intervention specialists and the role that they play at local health departments like Harford County. We'll talk about Harford County Health Department services, so you have an idea about those. Linda will review for us the impact of trauma and the social determinants of health and how that contributes to rates of STIs and uptake of services. And then we'll discuss the future of our work in Harford County and some things we have rolling down the pipeline. All right, so first, there we go. First, a little bit of data on chlamydia, reported cases and rates in Harford County. These years are between 2016 and 2020. Just a disclaimer for all of my data slides that are coming up. The data in the presentation varies from slide to slide of going up through 2017, 2018, or 2020. Part of the reason for that is it takes time for final numbers to come out. Part of it may be not after 2018 due to a recent network outage in the Maryland Department of Health. That is, along with the pandemic, limiting our ability to access historical data. So hopefully we'll have updated slides moving forward once our network gets back online, but bear with us. If you do have specific questions about data that's not presented here from more recent years, definitely follow up with us and we can share that with you afterwards. Okay. So this slide just shows both cases in the bars, and that line that's up above those is the rates of chlamydia in the population in Harford County, and that rate is per 100,000 population. So what we the takeaway for this slide is that COVID-19's had an impact on service utilization and testing, meaning that reports were likely much lower during the pandemic than actual case rates in the population. And so if you look here at 2020, the fact that in the year 2020, we only had 914 cases, when in 2019, when utilization was sort of standard pre-pandemic was 1,041. That's a very small difference in numbers, given the fact that we know that people were not getting tested and were not accessing services. And so what we anticipate is that as future data does come out, we may realize that there was just a lot of chlamydia that was going, that people were not getting tested and therefore were going undiagnosed, and these numbers may actually be much higher. Rates of reported cases of chlamydia by age and sex in Harford County, and this is for the year 2018. Again, the most recent data we have due to our network outage. We see the greatest burden for chlamydia is in the 15 to 24-year-old age group, and rates are higher in reported cases among females than males. Remember, routine screening is important for all age groups, but really especially think about those 15 to 24-year-olds, and recognize too that men may not be getting tested as regularly. And so the rate among men may be artificially lower. So encouraging male patients to get tested is going to be important. These are the rates and cases specifically among that 15 to 24-year-old age group from 2014 to 2018. We see an increase of more than twofold in actual case numbers from 2014 to 2018. And on average, about 7 out of every 10 reported cases are among this 18 to 24-year-old age group each year during this time period. Remember, again, screening and testing are just super important among these ages. Gonorrhea cases and rates in Harford County, and this is again back to that 2016 to 2020 range. We see the cases and rates both rose between 2016 and 2020. And the same thing that we saw with chlamydia rates, we see gonorrhea probably also there were lower reported rates based upon less access to testing and less uptake of testing services during the COVID-19 pandemic. So they may be artificially lower than these reported rates than the actual rates in the population. And so as folks are opening their doors back up, as you're seeing patients again, as you're doing testing, really be encouraging even more now than ever folks to access those testing services. Check when's the last time you got tested, especially if it's been pre-pandemic, please get tested again. The fact that 2020 numbers again were comparable to 2018, we see again, same thing. The 2020 actually were higher than the 2018 numbers in Harford County. 2020 was right in the middle of the pandemic. Testing services lower, higher than our 2018 numbers. There's probably a lot higher rates going on in the community than we actually realized due to the lack of testing. We see that the 20 to 29-year-old age group has sort of the highest counts and rates in Harford County when it comes to gonorrhea. Again, routine screening important, especially for young people. Among that 15 to 24-year-old age group, our gonorrhea rates increased between 2 and 3-fold from 2014 to 2017. So stuff is trending up across the board. This is something too, just a random point to note, we're in the middle of legislative session in the state of Maryland. There's been over time historical defunding and the spending power of public health dollars around STIs has decreased and continued to do so over the decades. As you see these rates going up in our community, if you want to do something about it, there's the clinical component of actually providing these services, testing patients, doing the screening, getting people treated, doing that work. There's also putting additional resources into our system to allow us to continue doing more of this work. So maybe do consider some advocacy as well. Reach out to your legislators, advocate for additional resources so we can get these numbers under control. For primary and secondary syphilis, 2016 to 2020 in Harford County, note that our cases and rates peaked in 2016, and we don't necessarily have the greatest explanation for that, but I believe that was in line with what was happening across the rest of the country and around the state. We see here in 2020, there was a huge spike right in the middle of the pandemic at 15 cases in Harford County, which is a significant increase from 2018 to 2019 pre-pandemic. We don't have the largest population in Harford County in the state, and so it's challenging to draw conclusions when we're working with such small numbers to say whether was this just an anomaly or was there something else going on. But I will talk about our DIS, disease intervention specialists, the work they do to help us try and figure those things out, which may in the future give us a little bit more insight into exactly why those rates go up and down. So rates reported by age and sex of primary and secondary syphilis. This is for 2018. We noticed that there's a much higher burden among males, much higher case rate among males of primary and secondary syphilis. A lot of this has to do with how syphilis is transmitted and how effectively it's transmitted via anal sex among men who have sex with men. So remember, men who have sex with men are one of our populations that's a disproportionately higher risk for syphilis. And so as we'll hear later today about how to take a proper sexual history, get some good information there about identifying people's sexual behavior, talking to them about their sexual identity and orientation, and possibly identifying men who have sex with men to really do some more targeted screening for folks at higher risk for syphilis. Primary and secondary syphilis broken down by sex and sexual behavior. So this we see the syphilis that we are seeing in the community, how are people getting it and who's getting it? And sort of our categories are men who have sex with men who have sex with only females, and then females, it's just anybody who is identified as female sex at birth. And what we see again is cases peaked in 2016, as we saw in the previous slide. There's specifically a huge increase in 2016 as well among men who have sex with only females. Potential reasons for that: opioid epidemic. Relating to that, there was also a slight increase in females that year, but we didn't necessarily see that sustained over the following year. So it's possible that it was just an anomaly. We may not have a very good explanation. So now I'm going to talk a bit about HIV, the epidemiology of that in Harford County. In Maryland overall, there are 31,676 residents living with HIV in 2020, with 724 of those being new diagnoses in 2020. In Harford County, on the other hand, right up there, circled in northeastern Maryland, we had 525 total Harford residents living with HIV. 11 of those were new diagnoses in 2020. And you'll see our rate per 100,000 population is in the 0.1 to 5.1 people living with HIV per 100,000 population in Harford County. So we're on the lower end for the state there. Which is not to say that those people in Harford County living with HIV do not have a significant amount of need for our services. We do see at the county level, some zip codes are seeing declines while other zip codes are not. And so we've sort of overall seen a trend of decreases in new HIV diagnoses, but it's not necessarily been equitably distributed across the county. So in terms of people living with HIV who's diagnosed in Harford County, we see that the rates per 100,000 were twice as high among males compared to females. Note that. 50.3% of people living with diagnosed HIV in Harford County were non-Hispanic Black, which is notable, especially in a county where we're predominantly white. Means the rate per population is much higher of HIV diagnoses among people of color. And we also see that HIV has a greater burden among non-Hispanic Blacks than any other racial ethnic group, not just the non-Hispanic whites. So you see the statewide graph up at the top left. This shows HIV diagnosis trends by exposure category. And this is showing 3 different types of exposure, the way that people might have contracted HIV. The first being through sexual contact among men who have sex with men. The second, injection drug use. And the third being heterosexual transmission, regardless the sex of the person who contracted HIV. And what you might note there, 1990, this huge peak in the state among people contracting HIV through injection drug use. This was largely due to, in the city of Baltimore, huge HIV pandemic among people who were injecting heroin specifically. It was like at one point in time, over 80+% of all people who injected drugs in Baltimore City were diagnosed with HIV, which is just epidemiologically speaking astounding for something like that to happen, especially given that HIV doesn't transmit nearly as readily via injection drug use as it does through other methods. But then we see it starting to decrease. And that star right there on the graph is in 1994, when the Baltimore City Health Department launched its needle exchange program. This program was associated with a significant decline in HIV transmission by providing sterile injection and drug use supplies to people who injected drugs. And part of that success has led Maryland to actually be looked at by the federal government as a model for implementing syringe services programs to address infectious disease epidemics, and has led to, in 2016, Governor Hogan's signing of the SSP Expansion Act to authorize syringe services programs statewide, and eventually the authorization this year of a program in Harford County. So there's just some other charts with a little bit of extra information about breakdown by exposure category of how people contracted HIV. At the bottom, we see specific to Harford County. What you'll notice is that most cases of folks living with HIV in Harford County contracted it via sexual exposure, as men who have sex with men. Heterosexual transmission is the second highest exposure category, and a smaller but shrinking portion contracted HIV through injection drug use. And again, shrinking probably due to the expansion of services for people who inject drugs to access safe supplies so that if they're living with HIV, they're not transmitting that to their either needle sharing or sex partners. This is a yearly breakdown of HIV diagnoses in total, new diagnoses each year in Harford County from 2011 through 2020. And again, you'll see it's sort of gone up and down a little bit over time because we have a relatively small population size in Harford County compared to other parts of the state. But there is an overall downward trend. And this is what we're also observing, not just in the state of Maryland, but nationwide. Again, we see these decreases in incidence and they seem to be sustained, but it's probably necessary to see more years of data, especially given the lack of testing and lack of uptake of testing, even when it was available during the pandemic. We may see that this 11 new diagnoses in 2020 could be artificially low. We may see increases once the 2021, again, 2022 numbers come out as folks who contracted HIV during the pandemic get linked to testing and we make those diagnoses. Co-infections. Co-infection of STIs among folks living with HIV can be incredibly common. This is a note for both HIV providers to be really testing regularly your patients for other STIs and for STI service providers to also be including HIV testing regularly in those panels. People with HIV do still have healthy, robust sex lives, and again, definitely should receive routine STI screening. The risk of HIV acquisition also increases with multiple STI infections. One, because of just associated risk behaviors. You're engaging in risk around HIV acquisition. Some of those same behaviors bring risk around contracting STIs. And the second being can be increased susceptibility at the exposure site. So if someone's living with HIV or has an STI, it can reduce your immune response at the site of exposure and increase your likelihood to contract another infection. Hep C. Tiff, this one's for you. You'll hear later today from our fantastic Hep C navigator at the health department that works with patients living with hepatitis C. Hep C in Maryland and nationwide and worldwide, viral hepatitis leading cause of liver cancer. See here at the bottom right, we've got a nice little picture of a normal liver on the top left, and then the hepatitis C virus that hops on in, leads to a cirrhotic liver, and eventually, if untreated in the long term, becomes a chronic infection and progresses, can lead to end-stage liver disease and eventually morbidity. This was an estimate from 2017 or 2018, there were between 47,000 and 73,000 Maryland residents were expected to contract hepatitis C in their lifetime. That's a lot of people. That's a whole lot of people in a state of just a few million population. Right, and estimates by CDC estimate that 1 in 3 young people who inject drugs have hepatitis C. So one thing we do with our Hep C services is really target populations of people who use drugs and with other substance use disorders, because there's a lot of transmission there, and testing and surveillance have historically been very, very poor for hepatitis C, which means there's a lot of previously undiagnosed, untreated chronic Hep C, not just among these younger folks, but this chronic Hep C among older folks who may not have been tested and been living with Hep C long term, with the potential for spreading it to partners and developing late stage consequences of hepatitis C infection. 2010 to 2017 numbers from the National Electronic Disease Surveillance System that just shows the cases of people living with chronic Hep C totals in Harford County. These increasing numbers probably reflect increasing incidence of hepatitis C as a result of the opioid epidemic. And you see down here, we just see opioid-related deaths increasing. These charts are on different scales, but I put them side by side just to show that it's the same increasing trend over time among hepatitis C and opioid overdose deaths, and we really can't tease out those two pandemics. But note that it's probably not just increase in incidence that leads to these increasing reported cases of chronic hepatitis C. It's probably also increased availability of testing. We probably had a lot of cases out there for a very, very long time, and we just were not detecting them. There's definitely a big need for safer use education, syringe access, as well as increased testing for hepatitis C and access to treatment services. So A little bit back to, I mentioned the disease intervention specialist piece. We do have staff people at the health department that are, I don't know, show of hands for folks in the room and maybe get hands on for the virtual component. Who knows what contact tracing is? Every single hand should have gone up at this point. We basically started preparing this presentation 2 years ago for an event that ended up getting canceled as a result of the pandemic. And at that point, I was talking to Linda earlier, I was like, I don't know that anybody, we would have had to explain contact tracing to a lot of folks in the room. I don't think we have to explain it anymore. Disease intervention specialists are highly trained contact tracers that specialize in mainly sexually transmitted infections, especially HIV. Syphilis are the two big ones that our DIS, the health department, you'll hear from later today, focuses on, and also does support and assistance with gonorrhea and chlamydia. And sometimes we utilize their expertise to help track people down, lost contact with, maybe living with other infectious diseases. Their public health outreach workers are responsible for finding and then counseling folks who have either tested positive for an infection and don't know it yet, or potentially interviewing those folks who have tested positive, identifying their partners and their contacts, and then getting those contacts access to testing and treatment. There's a lot of research that supports the work of DIS. All right, and conclusions from it. One, integrating DIS at publicly funded STI clinics results in greater numbers of cases that actually get interviewed. These are folks who test positive for an infection. Using a DIS embedded in a local health department like we do increases the number of people that actually talk to us, give us more information. We can find out where their infection may have come from, identify the partners, get them tested and treated. And placing DIS within community HIV clinics, there's also research specifically on this that shows that it improves partner services. And it's a big recommendation that those programs should consider the method to improve partner notification. There are some myths about DIS. I don't know if anybody's ever heard of these. One, DIS is sex police. They're not. Your job's not to be judgmental and tell people what they should or shouldn't be doing. It's just to get people informed about their status and get them connected to resources. Second, DIS spread information about your sex life to friends, family, and coworkers. Also not true. Everything DIS do is entirely confidential between you and them, and then the staff at your lovely local health department that are working to support folks in the community. Third, DIS make home visits to your work and home in clearly marked health department vehicles. They don't. They don't. It's generally going to be an unmarked vehicle if they're coming by, and they're going to do everything they can to minimize the fact that they may work for the health department to protect your anonymity. And last, DIS are associated with law enforcement. Also not the case. Though our DIS do sometimes partner with law enforcement or go inside to like local detention centers in order to reach people to provide services. Their job is not law enforcement in any way, and their job is not to communicate with or cooperate with law enforcement or the criminal justice system. Their job is to focus on individuals who have potentially been exposed to an infectious disease and help them access the services they need to take care of that. All right, DIS work in different types of settings, largely health departments, but also in community health centers and other locations. Use a lot of ground level analytical skills, which are it's this contact tracing stuff that I think a lot of us learned about in the pandemic. And they also work in emergency preparedness settings. We didn't mention tuberculosis is also something that DIS can sometimes help with as well. They have great expertise in communicating, interviewing, counseling, case analysis, and provider and community engagement, and are often very, very embedded with community partners, really have an idea of what's going on at the ground level. And once they've connected with somebody, they serve as a patient navigator and a network builder, making sure patients get not just linked to care, but they follow through with the process, complete their treatment, get partners notified, and have the resources they need moving forward. So we've historically had our DIS when they connect with folks who have tested positive for HIV, syphilis, gonorrhea, chlamydia, that will make a referral to our PrEP program. Because if they're at risk for these other infections, they may also be at risk for HIV. And so this DIS are doing more follow-up to make sure that person's needs are met on an ongoing basis. They do a lot of work building trust, and there's definitely a component of data entry that we want to make sure gets included there as well. So the contact tracing process, essentially what happens, and again, I think a lot of folks are familiar with this now. First, they're interviewing the infected person. That's the first step. Find them and interview them and get information so you can understand who they may have potentially exposed to the infection that they have. Then in DIS work, it's identifying sex partners. That's name, address, phone number, other locations, anything that they can get on these other individuals who have been exposed so that they can reach out and say, not tell them so-and-so exposed you to X infection, but what they can say is, we have knowledge that you may have been exposed to a specific infectious disease, and we strongly recommend you come in and get tested and treatment if necessary. We'd love to help out. How can we facilitate making that as easy as possible for you? This is a really complicated contact tracing diagram, I believe from CDC, that just sort of follows the flow of how that happens. A lot of credit to our DIS for being able to follow these algorithms and many, many more. And I don't know, Logan, are you able to play this video for us? It's just a brief overview. It's a day in the life of the DIS that was produced by the National Coalition of STI Directors.
Every situation you deal with is a totally different situation. You don't know what you're walking into. Most people have a lot of issues going on, and the STD might be the smallest issue that they're dealing with. We've had times people broke down in tears. We've had times people say they're going to kill their partner. We've had all kinds of different situations.
You have to have tough skin as a DIS. Most patients don't want people that they don't have a relationship with coming to their door telling them about an STD that they have.
We deal with people in shelters. We deal with people who may haven't eaten in the last couple of days.
We actually get to see the reality of our patients.
For a DIS, it's not that big an issue for us to go in our pocket and buy them a meal or buy them some water. Just let them know that somebody actually cares about them. One of my brothers died from HIV. So it's a vested interest in me that we're here to offer them the services that they need. I really love this job. That's why I put so much effort and so much care in what I do, because I've been there. And I understand how it is to be at the bottom and feel like there's no way up. We have a really tough job where you got a person that's going to trust you enough in 20 minutes after you knock on their door to tell you the most intimate things in their life, to trust that you're going to take care of their confidentiality, and to also trust that you're going to make sure their partners get in, get examined, tested, and treated. We try to do everything we can do to make the person relax and understand that we're on their side. Good morning. I'm looking for John.
Listening to what the patients have to say is really where you find out what's really going on with that patient. It leaves that patient walking away feeling like they could trust you with the information that they provided you with.
Because we're able to go out and actually let people see that the health department's actual human beings and people just like them that are working, trying to make sure that we protect them from contracting these infections. And if they are infected, get them treated, get their partners in, so we won't have to deal with this situation anymore. We have made a determination we're not going to fail because we can come out and do the work that's necessary to make sure that we win. Most people who work in the health department don't know what DIS are. They don't know what we do. We do a pretty good job in making public health better in the country, I think.
For me, that's rewarding. That's what I enjoy out of this. When you see patients and they come back and they say, thank you for going the extra mile to track me down. Thank you for not allowing the way I was treating you or the attitude I gave you to stop you from helping me get what I needed. We
really have to do the best we can to continue offering these services to folks. So that's why it's really important that people fight for their health department and fight for their public health clinic.
You will hear from the disease intervention specialist briefly, who works for the Harford County Health Department a little bit later today. I'm going to go ahead and pass it off to Linda.
I love our GIS. They truly are a gift to this earth, and our sexual health team couldn't function without them. So please send a DIS today if you can. There is one in the room, but I can't point her out right now because she's shy. She's shaking her head over there. And then the data that Zach presented, oh my gosh, that's why we're here. There's a whole lot of work we still need to do. So hopefully you'll get some ideas from this and then take it back to your community settings and really improve the health of our clients. So my piece of this talk will focus on some of the various services we offer at the health department. I'll talk a little bit about our philosophy of care when providing services. I'll point out some specific strategies that we use, and I'll share some of our future plans. We are, as you can see here, a multi-site health department, which can make it difficult to give like warm handoffs sometimes, but it also gives us a presence in various areas of the county. We have a very widespread county, north to south. It's just very, very large. So having these various settings does help. We offer STI clinic currently. We have a hepatitis C clinic where we offer screening and treatment, which we're very, very proud of that. Not many individual health departments actually offer the treatment piece, so we're very proud of that. We have a prep clinic, which is kind of a combination right now of telehealth and in-person. It seems like several of our clients still like that telehealth piece. We kind of learned that through COVID, and we're trying to keep that going as long as reimbursement's there. We have an HIV medical case management team, super, super talented. Testing and linkage to care through the wonderful work of our DIS. Family planning services. We're really proud of our success in promoting LARCs in the community, keeping pregnancies on the lower side. We have an outreach team that will go out to treatment centers, the detention centers, schools, university setting, a harm reduction and overdose prevention team, which we just very robust naloxone distribution team that we just try to saturate the community as best we can. Dental services, and we also offer health insurance navigation, all those things currently. And then this actually is where we all live. Most of the people in the room here are from this actual site, and we provide services here. And we hope in the near future to offer low threshold buprenorphine treatment. We're working currently on screening algorithms, service algorithms, standing orders, peer navigation, how that might look, and on-call policies. So hopefully this is close to fruition. We are hoping to expand HIV treatment options for our clients, and that includes also primary care. That seems to be the trend now, kind of that one-stop shop, try not to go too far, so we're hoping to really expand those services. PEP seems to be a low access item here in the county, so we really would like to collaborate with the hospital, pharmacies, and the health department for referrals and to get that service to our clients in the county. An outreach mobile unit, can't wait for that to happen. Hopefully it'll start more as the outreach team for screenings, but we'll eventually develop more advanced services, wound care, hepatitis C screening and treatment, and the primary care that I had told you about. But even, as you heard in the DIS when he was speaking, even with all of these wonderful services, if other things are going on in the lives of our clients, prevention and cure will definitely have low priority for these folks. Finding a place to sleep, getting food for their family, or even getting some heroin to make it through the next day, those things will become more important than actually taking your HIV meds or your Hep C meds. And so when we plan and develop our programs, we promote a philosophy of care that looks at the whole person. It addresses as many needs as we can with that individual that's in front of us. And this takes definitely a comprehensive approach, a comprehensive team of outreach workers, DIS workers, peers, social workers, the nurses, the providers. It takes a village, and it involves a caring attitude and an open mind so that our clients will trust us and they'll want to stay connected and engaged no matter what's going on in their life. And the hepatitis C patients come to mind for this because we'll work our tails off to get them diagnosed, get their prior auths for their medication, and yet life happens and we lose them. So having that warm understanding with them, positive rapport, it creates an environment that allows every patient interaction to become an opportunity for education and hopefully become positive health goals for them and outcomes. Many of our clients definitely walk through our doors with layers of trauma. And I like this definition of trauma in particular. Sampson says, trauma includes events or circumstances experienced by an individual as physically or emotionally harmful or life-threatening, which results in adverse effects on the individual's function and well-being. And this trauma can stem from a variety of things, from physical, sexual, or emotional abuse, childhood neglect, poverty, discrimination, family members with behavioral health issues, sudden separation from a loved one because of divorce or death or some other reason. And we see these traumas manifest in various ways: drug use, health issues like STIs, liver disease, cardiac issues, autoimmune disorders like psoriasis, and even depression. So how do we effectively help our clients? We try to consistently provide trauma-informed care. As we offer our Hep C treatment, our PrEP services, our HIV case management, we recognize that folks come with adverse childhood experiences, racism, poverty. They can prolong the stress response and negatively impact our clients. As we offer our family planning, STI treatment, we do our best to understand the client as a whole, of their life experiences, where they're coming from, and we definitely want to meet them where they're at. This actually empowers them, it improves engagement, it can promote adherence to care, and hopefully ultimately heal our clients. And using an approach that focuses on what happened to you as opposed to what's wrong with you can have a much more positive healing effect on clients. And this definitely involves understanding the social determinants of health, such as education, income, environment, transportation, or lack of any of these things. And these can create barriers to health promotion and impair healing. And of course, we also look, like I said, at the adverse childhood experiences. Epigenetics has come into light lately, especially with rising mental health concerns. And as you may know, epigenetics is that study of how the environment and other factors can change the way that genes are expressed, and gives some explanation as to how these external social and sometimes traumatic conditions can actually change brain development and may affect learning abilities, social skills, and result in long-term health problems. So as we develop our programs and we plan our care, we try to create an environment that sort of levels the playing field. Healthcare has done pretty well so far in getting past the idea of equality, that first block there. We all know that people are different and that the same cookie cutter healthcare approach doesn't work for everybody. And then equity, that second block, that looks a little better too, but still not great because there's still barriers that exist that can prevent full engagement in healthcare. We're still seeing poor birth outcomes for some of our clients, our ladies that are living in poverty or that just have poor access to prenatal care. And take a look at liberation, the third block here. That definitely looks better. The walls have come down, the players are closer to the field. But imagine a model where the provider and the patient are truly on the same team and fully engaged and interactive in health promotion, possibly that fourth block there. And here are a few strategies that can perhaps get us closer to a model that might be the fourth block. Lead and communicate about being trauma informed, be champions, teach your whole team about some of these principles. Engage patients in organizational planning and treatment, form community advisory boards, do needs assessments, get that buy-in from the clients in the community, because it can definitely help you have better health outcomes. Create a safe environment so clients feel comfortable coming to your space, because guaranteed, if they feel any hostility, discrimination, stigma walking through your doors, they will not ever come back. Screen for trauma. There's several tools out there. There's a brief trauma questionnaire, the traumatic life events questionnaire. Indirectly, a lot of us are using SBIRT now, or the PHQ-9 for depression screening. Pick something that works in your clinic and your setting, so that hopefully you can identify some of these issues early. Engage partners that may offer further resources for your clients. If it's something out of your scope of practice, be sure you have that warm handoff person that you can send your clients to, so that they're not left in the dark. So this is kind of our goal. I like this cartoon model created by the Women's HIV Program. located at the University of California, San Francisco. It depicts an easily all accessible care center that's affirming, safe, trauma-informed, and it definitely promotes safety and healing. But one piece I find that is missing is that mobile piece. I still feel like clients aren't always coming in your doors for various reasons, or they can't get in your doors, transportation issues, work-related childcare, whatever those social determinants of health might be in their life that are just not allowing them to come in. So that mobile piece definitely can come in handy. So what specifically do we do to get close to that model of care? We offer comprehensive care by a comprehensive team, like I said, the peers, the social workers, educators, all those people in your village will definitely come in handy and are necessary. We provide cultural humility training, and we'll come to you. It definitely creates that safe space for folks so they feel trusting and welcomed in your care center. We offer affirming care. Do not misgender or dead name. Most people, hopefully everybody knows what I mean by dead name. That's when we don't want to call, say, our trans folks by their birth name when they've actually changed their name to something as they're transitioning through their, as they're making their gender transition. And we definitely don't want to correct, we definitely want to use correct pronouns. Screen everyone, HIV, Hep C, hepatitis B, syphilis. Use the reverse algorithm. We highly recommend using that to kind of correctly diagnose your syphilis cases. Gonorrhea, trich, and chlamydia, of course, you want to screen for. And we offer extragenital testing. Can't tell you how many times a urine screen will come back negative, but a pharyngeal or rectal swab will come back positive if that's an area of exposure. So definitely screen all sites. We also realize that age is not a condom. In other words, we don't forget our older folks. 85-year-old Mr. George, who likes to fulfill his needs at the massage parlor, still needs syphilis education because syphilis likes the massage parlor these days. Provide outreach testing, HIV, Hep C, that kind of engages you with the community, builds trust. We offer our partner services with our wonderful DIS. Offer screening and treatment for hepatitis C in a low barrier setting. In our place, you do not have to be clean for 6 months before we treat. The goal is cure, and we can do that right now. Help clients get insurance. We incorporate billable services for sustainability. That's particularly important for us because a lot of our services are grant funded, and those grants necessarily will not be here in the future. So we're definitely trying to maintain the many services that we want to offer our clients. We collect data, and this too is important for getting the necessary dollars for the services. It's also important as a means to identify community needs that will drive revamping your services if you need to change or upgrade. We offer naloxone. We provide PrEP services. We find low to no cost Descovy and Truvada or the generic FTC, TDF. I know prior auths can be a major headache. We see that in our hepatitis C clients especially, but as you're developing your programs, I highly recommend that you consider an extra person for that. I know the other day I spent like an hour on the phone for a particular HIV prior auth, so it does take time, but it's definitely worthwhile because it is hard for our clients to manage those things. We make personal calls and texts to help adherence, and this really helps identify when something's going on. If a client has stopped taking their medicine, it's likely due to an issue. The system probably is failing the client for some reason, and we need to kind of help and be there, some extra special hand holding during those times. We offer provider detailing regarding PrEP, hepatitis C, STIs. We'll come to you with literature, with education, and we love doing this because that actually increases access in the community for our clients. We advertise on social media and other spaces. We have ads on Grindr, we have commercials, movie ads, bus ads. We'll go visit the barbershops for education. And we definitely promote U equals U, undetectable equals untransmittable. Science shows that if your HIV viral load is undetectable, you cannot transmit the virus sexually to your partner. And this is a great message when helping to decrease stigma. And one thing that we didn't put up there is that we do screen for substance use and mental health concerns, and then we will give a warm handoff to a mental health provider as needed. Some of our future goals, like I said, the primary care, hopefully for our priority partners, we probably will start with HIV. We also would like to address pediatrics in the area. Several of our families have Latino families have come to the area with no insurance, no care, lots of children. So hopefully we can fulfill a gap there. We want to start offer rapid starts for our newly diagnosed HIV positive clients. We would like to offer post-exposure prophylaxis treatment, hopefully in collaboration with the hospital, local pharmacies. We want to get that mobile health team up and running again, starting probably with outreach and then expanding to wound care, family planning, Hep C screening and treatment. We want to get our low threshold buprenorphine treatment up and running. We also want to have continued collaboration with the schools. It's a great place to expand, develop your community or your school-based health clinics. We're offering STI screening, family planning services. There is a rumor going around Harford County that our children, of course, do not have sex. So we do have to address that first, but hopefully we can work with the schools and get some valuable services up. Of note, MSDE is transitioning oversight of these programs to Maryland Department of Health, which might give us actually a chance to get our hands in there to really help. We'd like to offer Uber or other ride sharing for clients. And then we'd also like to offer on-site telehealth, mental health provider services, just as mental health needs are definitely on the rise. And so by incorporating all of these strategies and future goals in our care services, we hope to see better health outcomes for Harford County and surrounding communities. And I know it's not easy. We know it's not easy. Money, politics, staffing issues, COVID, all those things got in the way of making your plans, and you might actually feel like that lizard many days we did. But continue to expand your knowledge. Be at the table when legislation is being discussed. Like as Zach said, we need money to support these programs. STI screening treatment programs has not seen funding in many, many years. Network with colleagues, listen to your clients and collaboratively develop plans. That'll give you the buy-in and hopefully will improve your outcomes. And just unleash your superpowers, lean into the discomfort, dream big, because assuredly you will increase the opportunities for your clients in the communities to live the healthiest life possible. And that truly is our ultimate goal.